Good afternoon. We are delighted that you're joining us today. I am Alexander Blunt, and I will be moderating our webinar. This is the 6th webinar, which let me share it with you. Share our slides. So, this is the 6th in a series of webinars on integrated behavioral health in primary care and other medical settings. And the address of the other webinars will be on the final slide. If you want to see them, they're all available online. Our title today is Completing the Integrated Workforce, How Care Enhancers Can Contribute to the Care of Patients with Complex Health Needs. Originally, the title said How Community Health Workers Can Contribute, but I changed it to Care Enhancers because we're talking about a role, not a title. And the role is we'll get into in some detail, and we're going to have 2 examples of that role, each with different titles in different settings. And those examples will be given to us by Dr. Ebony Winford and Dr. Anna Dobany, both with us today. Dr. Winford is Director of Research and Health Equity at Cherokee Health Systems. Cherokee Health Systems is one of, if not the more evolved health systems in relation to integrated behavioral health being part of health rather than a topic to itself. It's basic to everything that is done in that health system. And Dr. Winford is a national expert both on integrated care, but also on how integrated primary care can interdigitate with the community and the community's needs to be part of a larger service system and a larger community approach to health equity. With us also, Dr. Anna Dobany. Dr. Dobany is a medical director of Penn Medicine Home Health and the Director of Population Health in the Department of Family Medicine and Community Health at the University of Pennsylvania School of Medicine. She is, by the way, one of 2 receivers of the designation of Family Doctor of the Year in Pennsylvania in 2017, and she continues to be a Family Doctor of the Year. I worked with her for some time at UMass. So we will get started. We were going to ask you, if you have questions, to put them in the Q&A, which is at the bottom of your screen. I'm going to be able to watch the questions, and I'll give them back to our presenters as we come to the end of the webinar, and we expect to have some time for questions at that time. These are our conflict of interest disclosures. Let's start out with an overview or a setting of the problem that we're addressing today. One is that some patients need an enriched care team, and that the evidence for that is very strong. The extra team member is called for in what I would call bodies of literature on patients who are, some in one body of literature, they're called complex or high utilizing. I think most of you are familiar with that term and with who we're talking about. In another body of literature, they're called patients who are disadvantaged, low income, challenged in relation to education, or folks who endure bias or racism regularly in the courses of their lives. And there's another body of literature that talks about people who are trauma victims, people with diagnoses of PTSD or with high adverse childhood experiences screens. Those folks in all three literatures are said to need an extra team member. And that extra team member is someone who helps engage patients in care, offers them guidance in accessing the larger medical system, sometimes called navigating, helps connect patients with community resources, and helps educate and support patients in relation to their health goals, sometimes called health coaching. All three of these bodies of literature, in describing who they're talking about, have multiple overlapping descriptive terms. What I think you'll see is that, in fact, we're talking, at least statistically, about the same folks. And if you're interested in seeing the literature broken out, take down my email address at the end and ask me for it, and I'll send you a chapter where it is. So in this group of folks have a higher incidence of depression, anxiety, medically unexplained symptoms, substance use disorders, chronic illnesses, multiple chronic illnesses such as diabetes, osteoarthritis, lung disease, metabolic risk markers or obesity, hypertension, heart disease, homelessness, or insecure housing, and problems with the social determinants of health. They are also described in relation to health professionals, how they and health professionals relate. And they are described as having difficulty forming trusting relationships or partnerships with health professionals. They tend to be suspicious of health professionals. The health professionals often are more frustrated in relation with these folks in trying to give them care that they think they need. The health professionals experience extra stress in working with these folks, and they tend to underestimate the incidence of trauma. Often health professionals become less patient-centered in working with these folks. The data says that even very patient-centered physicians will become less patient-centered in the sense that they become more directive and less offering of partnership with these folks. And the aspects of effective care, all three literatures say, is that when the health professional evinces a commitment to making or partnering with the patient in their care plan, when the health professional takes a strength-based approach to the patients, and when the health professional is part of a team providing good care, things go much better. In fact, these folks are all around us. We often just don't bother to take them into account when we're talking about integrated care. This is a survey that was done in one state, all the safety net clinics, the FQHCs and the rural health clinics in one state, happened to be New Hampshire. And of the 21 clinics, 15 responded. And those 15 represented many more sites than that. In that year, 2018, the BHCs, the behavioral health clinicians, were 64 in these settings. And the setting said, well, yes, but we would need in 5 years 127, they guessed. Psychiatric clinicians actually were less in need. They had 43, and they think in 5 years they'll need 57. But then there was this whole other group, 98 currently in 2018, and in 5 years they expected to need 215, 120% increase. And these folks, the clinicians, these groups were called health coach, navigator, patient advocate, care educator, patient educator, community health worker, care coordinator, and care manager. And as we read the job descriptions of these various folks, we found no consistency between either the same title in different settings would have different job descriptions, and the same job descriptions in different settings would have different titles. So, and what were these people doing? Just what we highlighted before, helping engage patients in care, often offering lived experience that helped them engage the patient, offering patients guidance in accessing care, navigating, helping connect patients with other community resources, and helping support and educate patients on their health goals. So we called them care enhancers because we needed a term that didn't have a title with it, that it was general for the role. I don't think that's going to catch on as a title, but it helps, I think, in this situation. So let's ask now for Dr. Dobany to talk about the experience of working with this role, these folks, under, in her program, the title of care managers. And Dr. Dobany, if you would.
Thank you so much, Dr. Blount. And I'll give you a little bit of background just so you understand the perspective from which I'm working. I have been the last 10 years in a very large urban underserved practice of about 22,000 patients. And during that time, I've been involved in the development of a program, an intensive primary care program for care management for patients who experience high ED utilization and have mental health needs. And then in addition to that, I've also worked on a centralized development of a centralized model on a service line level. And now I teach complex care management as well as the physician lead for a payer-based practice, a payer-supported practice-based care management team. So I kind of come from a perspective of a lot of different ways of trying to integrate care enhancers, as Dr. Blount has called them. In the program that I'll describe in a little bit, we call them care coordinators. I've also worked with care managers, and the roles are you know, it's not the title, it's the role, as he said. So I'm going to talk a little bit about some care management principles that I've developed over the last 10 years of doing this work, starting with this slide here that highlights the need for connection, coordination, collaboration, and what I call finding the joy. Starting with the foundation of team-based, the care management has to occur in a team-based environment. Although the team may vary dependent on the context, it should be built with that capacity to see the patient or the client as a whole, integrating all components of the person into one through internal and external supports. So with that in mind, your connection focuses on developing communication pathways that are time sensitive, relationship focused, and adaptive, leading to improved outcomes. Your coordination focuses on reducing the negative impact of siloed care management activities when multiple organizations and care management roles are involved, to reduce the redundancy, the confusion, the cost, and the decreased engagement that can occur in those settings. And your collaboration focuses on co-developed interventions, not just communicating the interventions that each organization or team is doing, but actually teams working together to co-develop interventions that are responses to the patient's needs. With all of that, I found out after having a team that got burned out that you have to include finding the joy. So finding the joy is important for engagement of both the team and the patient or the client, because focusing on the patient's problems and identifying ways to fix them, which is often the role of a care management team, leads to the patient or client becoming defined as the problem, and leads to burnout on the staff and disengagement on patients when they feel antagonism. Next slide, please. So Dr. Blount's already talked briefly around the work of care management and care enhancers. I'm gonna just kind of more globally talk about just resource management. Coordination between healthcare deliverers is an important role for care enhancers. Empowering the patient through self-advocacy, teaching self-advocacy, empowering healthcare deliverers minding the gap, which I consider identifying or anticipating where patients and clients might get lost to care delivery or might fall, quote unquote, fall through the gap. And then bridging that gap once it's identified, providing health education and providing longitudinal and episodic support. All of this is provided by those care enhancers. Go ahead. So I'm going to talk briefly about something I've developed conceptually, the umbrella model of care management. So when we think about healthcare delivery, often we talk about the safety net model, but the concept of a safety net often worried me because you have to have a fall for it to be of its maximum benefit. And so I've developed instead this concept of an umbrella model. So I want you to just take a minute and imagine with me that you're the person, you're the patient we're talking about or the client we're talking about, and you have a lot going on. You may have a physical or mental health disability or chronic illness. You may have difficulty paying your bills. You may have relationship struggles or be a single parent or struggle with substance use, fear, PTSD, or not have a stable, safe place just to call home. Think of this as the rain in your life. You will go wherever you can to get out of that rain, particularly if you don't have an umbrella. Think of that as wherever you can most easily access care. Could be the ER, it could be the hospital, the primary care provider, the urgent care, the mental health provider. It depends on your circumstance. Now imagine that at each interface with healthcare, because of your rain, you are given some form of care, quote, management, unquote. The ED social worker gives you information to shelters. The PCP's office calls you after every ER visit or hospital visit. The insurance company assigns you a service coordinator. The housing authority or corporation of aging gives you a case manager. These are all spokes. Now you're sitting in your rain with a jumbled mess of spokes in your lap. And when you try to get out of the rain, people chide you because after all, you have all the spokes that you need, failing to recognize that without anyone putting the spokes together, the cover on the top and the handle in place, you don't have anything like an umbrella that will help to keep you dry. In our current delivery models of care, a patient may have 5 to 7 care management interventions at one time that are frequently siloed and local to their vantage point: hospital, specialists, primary care, insurance, community-based social services, etc. In the umbrella model, think of the handle as the primary site of healthcare delivery and the spokes as other care management interventions not local to that site of care delivery. The team that connects the spokes and the handle is the cloth that holds it together and allows it to function as an umbrella. Without the handle, the spokes, the cloth, and someone to give it to the patient, there is no umbrella. Next slide, please. So this brings me to our priority access program, which I and a group of other colleagues at Penn Medicine developed for in our family practice office. And this particular program was designed specifically for patients who experience high ER utilization and had a mental health need, as I noted earlier. And so you'll see here just a list of the things that we did, that we provided for patients. Primarily, it was a 24-hour hotline for them to call, also for the hospital and the ER to call. So we'd have a chart flag in their chart in order for the hospital and ER to know that they were in the program and to give us a call for coordination. They had priority follow-up scheduling, weekly check-ins by phone or text messaging, whichever they preferred. And they had one point person for the patient. That's who our care enhancer primarily was, our care coordinator. She was really the backbone of the team that held us together and got the patients what they needed when they needed it. She would send messages to the rest of the team depending on what our discipline is and what the patient needed. We had weekly care management rounds, and during those care management rounds, we didn't just include our team, our core team, but we also included any teams that were also working with the patients. So there was an external community health worker team that was also involved with them. So it brings me to creating the team. And when we think about creating the team, I know that Dr. Winford's going to go more into the team members and what that looks like when you create this team. I want you to think more globally about what you need to do to prepare yourself to create the team. That includes knowing you, knowing your stakeholders, knowing your context, and knowing your capacity. So when you think about knowing you, excuse me, are you the primary care practice, the health system, the payer, a state Department of Health and Human Services, or a mental health provider, or someone else? Who are your stakeholders? Who pays for your services? Who receives the services? Who delivers the services? Who evaluates the services? And whose outcomes matter the most? Know your context. What are the needs to be addressed? What is the landscape? How do you integrate into a larger whole? What or who will facilitate or challenge the process or the program? Know your capacity. What resources can you support? What resources can you leverage? And what resource limitations do you have? And that may include not just monetary resources, but also emotional capacity. That really is important. We call that bandwidth these days, I think. And it can be mental bandwidth or it can be emotional bandwidth. Who is on the team? We'll go into that with Dr. Winford. I want to talk again globally about integrating the team. In the integration of the team, this can be challenging at the primary care level, where care teams are not local to the site of the healthcare delivery. Some of the challenges include each program having specific inclusion or exclusion criteria leading to clumping of resources and not optimizing resource allocation. This can cause some patients to go without assistance, while others get so much uncoordinated care they disengage. Additionally, patients will seek care where they find value. That value is often driven by relationships. If the care enhancer relationships don't tie back to the site of the healthcare delivery, then the patient may continue to use the ER as their high value location for low acuity care. I've used a hub and spoke model where a core programmatic team with a built-in docking process for external teams or team members can be a great way to have resources spread across stakeholders while still having the patient connected to one practice. It could be a health system centralized team versus a practice-based team, or even an insurance-supported community-based care management team, which has components of both the practice and the payer built into the same team. Whatever the model of integration, there needs to be a way to promote the connected, coordinated, collaborative care across the continuum in a way that reinforces the patient the value of their primary site of healthcare delivery. Relationship building between care team members is crucial for that integration of external and internal components of the team, particularly for care enhancers. This needs to be intentional, not just organic. Care management rounds can be used as a place for that, but it also requires a culture shift for teams used to focusing only on their own interventions. Next slide, please. So finally, I want to talk again broadly about evaluating the impact, because often we create the team and integrate the team without thinking about the evaluation plan. Evaluating the impact can be the most challenging component of developing an integrated model of care delivery, particularly if you have multiple external interventions that are docking into a hub. It may be important to integrate not just the team, but also multiple evaluation plans, since the spoke interventions may each have their own program evaluations. So here I've listed the key components of what I think are important for evaluating the impact, including outcomes metrics, but also process metrics. Often when your outcomes don't line up, when you look back, it's because the processes have dropped through cracks. I've included here something that I haven't seen in the literature, but I think a lot about is the relational metrics. Are people relating to each other? Are people communicating from one care enhancer to another? Are people communicating and relating to the patient? Are they encouraging the patient to communicate and relate back to their care team? So it brings me to the 5 C's, which I consider the primary foundation of your care management processes: coordination, collaboration, communication across a continuum at a cost that can be sustained. Thank you so much.
Thank you, Dr. Dobany. Dr. Winford, do you have a question or something you would like to underline in what you heard from Dr. Dobany?
The most impactful thing that I've heard, and I've been feeling this since we first spoke, is this notion of the safety net, the title being problematic because you have to fall first. And I think we use the term safety net so freely that we don't think about what that really implies. So the fact that your model flips that around and tries to prevent and protect the person from experiencing, the negative impacts of social determinants of health through this team-based care has always resonated with me since you shared that with me. And so I just want to highlight and make sure we don't miss that key piece with what you shared.
Thanks so much, Dr. Winford.
Yes, and I am guessing, though I bet we don't have time to go into it. I'll bet that there are a set of skills that are developed in coordinating across all of these organizations to keep them from getting in each other's ways, skills that we may not have been trained for or that we may not have recognized we needed in building these kinds of networks. Is that a fair statement, Dr. Dobany?
Yes, in fact, that is a completely fair statement that the National Center for Complex Health and Social Needs has worked really hard over the past 2 years to develop a set of competencies, core competencies, that can be used across disciplines. So it's not just for care deliverers per se, but it's also for care enhancers in different titles and roles. That highlights what is important, what those skills are that are needed in order to provide holistic care to a patient who struggles with complex medical and psychosocial needs.
That's great. Say again the organization that you were describing.
It's the National Center for Complex Health and Social Needs.
National Center for Complex Health and Social Needs.
Yeah, I would suggest you look at their blueprint for complex care, and then they also have a complex care competencies on their listed on their website. It's a very good document, and really they're now looking at developing a toolkit for people to use to educate care enhancers and care team members on these competencies, and then they're looking at developing a certification process.
Wonderful. Thank you very much. Now, Dr. Winford, please help us with your talk about your program where these folks are called community health workers.
Yeah, thank you for this. I will acknowledge first that I got a little itchy, scratchy throat going on. So you may hear me cough and or drink water, but just roll with it. So I want to talk about, moving beyond the PCP when we think about who's on the primary care team. Oftentimes when we think about primary care, even integrated primary care, the first two team members we think of is a primary care provider and then some sort of behavioral health provider. And as awesome as I think we are and know that we are not the team. We could not function without the other portions of the team that literally keep the things running day to day. Next slide. And, when we're thinking about in general, moving toward transforming into integrated care, moving away from the more siloed care or independent care, we have a couple different domains of transformation that we have to consider. And if you click the next, it'll highlight the two that I think are most important. So thinking about the service transformation, if you click the button for me, service transformation, when we think about multidisciplinary teams, there's so many disciplines. I'll roll with it. There's so many disciplines that together make a team. And we have to be mindful that clinically, we want to tap into the different skill sets that each member brings to the team. So at Cherokee Health Systems, this is who I think of as the primary care team. And I just want to spend a moment talking about 2 or 3 of these that we may not even consider members of the primary care team because they are absolutely care extenders. They're actually like the entry point to care, if you ask me. We call our front office staff and our centralized access and scheduling staff patient service representatives. They are members of the primary care team. Why do I say that? These are individuals who hear our patients every single time they call for an appointment. When they come into the clinic, they check them in every single time. When they leave, they check them out every single time. They get them scheduled for something every single time. They know the patients better than we know them because of the 15, 20 minutes we might spend with them, but they interact with them on at least 2 occasions every time they enter our space. If we don't consider the value that they bring to the patient experience when they enter into our spaces, we are not doing it right, because those are members of our team. As an example, I call them like they're my team members. I don't say my PSRs. They will send me a message and say, hey, the PCP is 3:00. Something's different. I'm just going to go ahead and put them on your schedule. And they are empowered to do that because they know our team. They know our patients. They know our model of care. They are part of the team. And if we only go by what their job description states, which is, to handle processing and admin stuff, scheduling, blah, 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 we would miss out on those key opportunities to extend the care we offer beyond this exam room into even the interactions that they have when they enter the space. So I always like to call, the PSRs the unsung heroes of the team. I don't think we give them enough credit for being amazingly strong team members. I also like to give props. We're going to go back one more time.
All right.
I want to give props to 2 more people before we get there.
Okay.
So I'm talking about our community health coordinators, but I'll tell you a story or so once we move forward. But other people we don't really acknowledge as members of the primary care team, maybe billing and coding and IT, like they have to understand what the heck it is we're doing in order to make sure that we get things done right. I do want to go back to the PSRs. Those are often individuals for us who are members of the community in which we serve. And that's another relationship builder that allows them to serve as care extenders. They grew up with the people who are walking through the door, or their kids go to school with each other. We are missing out on some good lived experience if we don't acknowledge the role that they play. I think that's why our community health coordinators and our community health workers are so essential to our team. In addition to, like I said, the other unsung heroes, the billing and coding and IT, I always make a point to like toot their horns because they're awesome. Next slide. Yes, insider information to some of our communities. That's exactly what it is. This is one of my favorite points to make when we think about, teams. Just because we got a whole bunch of experts on a team does not mean we are an expert team. Expertise is not defined by a degree. Expertise is not defined by the number of years of training you've had in one setting versus another. Experts might work well on tasks to check the box, like, yeah, we did that. But an expert team works together. And if we redefine our definition of expert, you will find that there are so many experts on our primary care team. For us, it's the community health workers, it's the front office staff, it's our nursing staff. Again, individuals who are more likely to be linked to the community in which we serve. They're the ones, and I'll just give a very frank example right now. Last summer, in the clinic where I am, it was scary to say the least. There is a high school, made it to national news, about 3 blocks down the way, where 5 students were shot within 5 months. The community health workers were ones who were like, I'm gonna go to the school and just give them resources and let them know that if they need anything, they can come in. Some of our staff members knew the families of the kiddos who were shot, and all 5 died, unfortunately. But they were able to say, you know what, this is what's going on in the community. So when they come in, be gentle. And it's been so helpful. Another unfortunate event happened last weekend. So we kind of prepped on Monday. Our community health workers and nursing staff said, hey, I just want to let you know what happened in the community this weekend. And I noticed that XYZ is coming into the clinic. I know that they have had experience with this before, so they might need you today, even if they're not on my schedule. I'm not in the communities, after, whenever I'm done, I go home, and I will admit that, like, I don't live in this community. I serve in this community, but I'm not here when things are going down. So our community health workers, our PSRs, our nursing staff are the ones that come in and say, hey, just want to give you a heads up, this really awesome thing happened, so when you see them, congratulate them on this, or this really difficult thing happened. So make sure you're gentle with them today. That's an expert team. Because if I were to say, you just checking people in, all you do is take blood, I would neglect to acknowledge that experience that they just brought to the table that just enhanced my understanding of the patient's presentation on that date. That's an expert team when we value each other's contribution to the care plan, even if it's informal. That doesn't get documented in a chart. That's the informal care planning that happens curbside, on the fly. But we have to recognize that expertise does not have to have 4 letters behind its name. Okay, next slide. And I think this is my final slide, and I love slides. I just like to tell stories because I think that really emphasizes, a lot of what we're talking about. In the medical world, we get real stuck on titles. Doctor blah blah blah, nurse blah blah blah, chief officer this person. I'm like, it's cool. I have my doctorate too, and there are times when I will be like, actually, it's doctor, right? Because again, there are times when that's appropriate. However, just because my title is behavioral health consultant does not mean that I cannot help triage and bring patients back into the exam room if the clinic needs it. Just because a team member's title is community health worker doesn't mean that they can't function as a key component of our team, providing contact outside the walls, bringing in context inside the walls, being the extension of care beyond the 4 walls that we have. And so looking at this picture, it's funny and it's not, because let's assume we got a door closer, we have a gurney pusher inner, and we have a driver. Who failed here? If we only go by title, the gurney pusher inner and the door closer failed. But if we go by function, meaning we need to make sure this patient gets in this ambulance and makes it to the hospital, the driver failed too. Because why didn't the driver check? Why didn't the gurney pusher inner close the doors? So when we separate title and think about function, we can see that we have so much more expertise on our team than we actually acknowledge. And that umbrella that you're talking about, the spokes that you're talking about, can be expanded that much wider if we take away our tension and our tightness and need to hold on to titles as tightly as we do, because I think that limits the roles that our team members can play. I want to share a story. I always have plenty of stories, y'all. One of the most compelling stories recently, we have a mobile clinic now, like we're big time, it's really cool to be able to, it's an RV that we essentially just pimped out. It's really, really cool. Right. But we have 2 exam rooms. We have telemed equipment up there. We have a RN. We have an admin person. We have a medical assistant, phlebotomist, and then we take turns having a primary care provider be on the mobile clinic versus telemed, and depending on, where we are. But one of our community health workers routinely on the weekends, just because that's how he rolls, goes out to the camps where people without homes live, so the homeless camps here, and just builds a relationship with people. That's literally that's his weekend plans. He builds a relationship with people. He gets to know them. That relationship has brought and driven so many patients to that mobile clinic because they know that community health worker. And now, because that community health worker is affiliated with this mobile clinic, which is affiliated with Cherokee Health Systems, the patient now has established a relationship. And because they trust the community health worker and the community health worker trusts us, the patient is more likely to trust us to provide care to them. So that's the context of this relationship. But because of the relationship that this community health worker has built up, there have been times when we've been out there. I go out on Tuesdays and do behavioral health stuff, but it's just fun. But because of the relationship the community health worker has established, there was a patient who was literally essentially on the corner, but needed help getting to a place to receive a service that had been arranged for them. And this person was in a wheelchair, and there's a portion of our community that's just straight uphill. And if you feel like garbage, you will not be wheeling yourself straight uphill. But the community health worker was like, I know that person. I'll be back. Left what we were doing, went over to the person, come to find out the person literally just needed to get up the hill to make it to this location. And they were like, all right, let's go. Pushed them up the hill, dropped them off, and then came on back. Like, no questions asked. Even though that person's title is community health worker, that person was a wheelchair pusher that day. That was the function, was to connect that individual to the care that they needed. And so if you have not considered ways that members of your team hold expertise, including lived experience, above and beyond what you can learn and obtain in a classroom, I double dog dare you to look further and to acknowledge the expertise that exists on your team. Again, our front office staff and our community health workers, they are the glue, and don't let anybody tell you differently. They bring so much knowledge and wisdom to the team, and I am made better as a result of their contributions to our team. And so again, if you haven't tapped into that source, I double dog dare you to do it. I think that's my last one.
Thank you so much, Dr. Winford. I'm going to go to our faces for people for the question part in a second, but I wanted to give people access briefly to the emails before we take the slides off. I want to make a comment and see if this fits your experience, Dr. Winford. In our last webinar on the 5th of May, I love the 5th of May, so because up in the corner it said Cinco de Mayo, and we got to do it just in the right day. It was about resiliency in the workforce, and the evidence studies were cited about protecting the primary care workforce, meaning the physicians, because there's been a lot of study of physicians' resiliency, a good deal more than other members of the team. And what the evidence said was that when the team had a flatter hierarchy, when the physician was active in recognizing the expertise of the other team members, physicians did not burn out as much. Physician retention, it was better, even in very stressful times like the COVID pandemic. Would you say that if we had a physician from, or a representative physician from Cherokee Health Systems, that they would concur with the idea of recognizing and utilizing the expertise of team members as experts in the part of the work that they each do?
I am literally like fighting the urge to go run, grab a PCP and cold call them and tell them to come in here and answer that question, because that's how much I trust that the answer is yes. And I've done it before, but I've looked at their schedules, they're packed. It would be mean of me to be like, come here for a minute. But no, I honestly think they would say that having a network of experts makes it such that no matter how complex a patient may present, no matter how many negative effects of like social indicators of determinants of health are impacting that patient, they do not have to do it alone. And you can tag in a team member. They can do this piece because that's their expertise. You tag in another team member, they can do this piece because that's their expertise. And when your team works well as an expert team, you don't have to ask. People are just waiting there like, oh, I got this. I saw that person was on the schedule. I'll do it. The same way our nursing staff prepped us on Monday about what happened over the weekend. We didn't ask for like the weekend prep. She just said, you need to be gentle for the patients coming in today. I think, again, if I were to cold call somebody, they would say absolutely having a team of experts, expert team has reduced their burnout and their likelihood to just want to walk away and leave. And
I'm going to ask another one that you may or may not be ready for, which is, so how much time is given to the team with each other during the course of an average week?
I
Is
think
it?
it depends, you know, like, and I'm speaking from a different experience. I think I've been with this team for 9 years. So like we have fought, we have, you know, like gone through some things. Like we're a resilient team. So we have at least 1 hour of dedicated time every week for our treatment team meeting. So that's just essentially every team member sits around the table. It's the most expensive hour of the entire week because we are not generating any revenue as we sit down and talk about patient care planning as a team. Okay.
Great.
And this is when like community health workers are saying, oh yeah, when I was delivering this food voucher to this person, I learned that blah, blah, blah.
Yeah.
And now we have more information. The other thing I will say is that, again, my 9-year-old team, we don't know how to stay away from each other. COVID was hard for us because we're used to sharing space. Like it was rare that I was in this office. I sat with the nurses or stood with the nurses, and the PCPs would routinely come through the nursing, area. The community health workers office is like right in line with the nurse's vision. So we don't like to be apart. So we make opportunities to be together. And I think that helps us with the relationships that we've established. COVID messed that up because we had to close doors and stay away from each other. We're gradually starting to get on each other's nerves again by bumping into them.
That's great. Dr. Dobany, did you want to ask a question as well or make a comment?
Yeah, no, I thank you so much, Dr. Winford. That was wonderful. And I really love the concept of making sure that we acknowledge the expertise of our front staff and our MA staff too. Ours, I find that we have, really worked hard to use other care enhancers, sometimes to the exclusion of recognizing how much those folks know and have developed relationships with patients. And I think often, at least in our practice, we focus so much on the physician-patient or APP-patient relationship, and we forget about those other relationships that are crucial to really doing good delivery of care across. So thanks so much for highlighting that, as well as the community health workers too.
So folks, I have to say that right now, the Q&A has no Q's in it. And so we're just going to keep on giving A's until you give us some Q's. So get on the stick. There's 93 of you out there, and I know you're bowled over by the quality of our presenters here today. That is a normal human reaction, but we really do need for you to use us up, or we'll just kind of meander a little bit. Let me go back to, and so I'm gonna, oh, here's a new message. See,
it's not a question though.
Yeah, people are putting things in the chat.
There's a question. There's a question.
You got a question?
What can you share about reimbursement options for non-Medicaid community health?
Oh, I see. Okay. Yep. Go ahead. What can you share about reimbursement?
I can share that I want to pull my hair out a lot of times.
Yeah.
I will also share this. There is a current funding opportunity for community health worker training and development of the workforce. So that is available. It's a $3 million grant delivered one time, but to last over the course of 3 years, where you can create an apprenticeship program, you can develop and train, give workforce development skills for community health workers. So that's one option. And I think that just draws upon the idea that a lot of community health workers have to be funded through grants because they aren't necessarily reimbursed by insurance companies. Now, it also depends. So we have community health coordinators, community health workers. The community health workers spend a little bit more time in the community than the community health coordinators who like coordinate and refer and things. But most of the time it is Medicaid that is the reimbursable thing. But then there's also some of the commercial ones that have the case management services that we can then use that. But for like lived experience, grassroots, real people, if you will, a lot of it is grant funded.
Yeah, the community health worker grant program does not have many days on before you have to get the proposal in. It's in the HRSA website. And it's pretty broad about who can be the training site, community college, universities, big health systems, a lot of different places could qualify to do it. One of the, if you go to, if you email me, I will give you a workforce website. I'm not going to give it out loud because you won't remember. And the workforce website will give you a sort of a way of building careers for community health workers becoming behavioral health clinicians for you, using a career ladder within your site. And I'll plug the Collaborative Family Healthcare Association is a national organization of people interested in integrated care. And it happens that there will be a plenary in the next one in Boise in October. And that plenary will be on this general topic, but with a lot more on the equity and diversity role of these folks in becoming part of the healthcare workforce in general, not just the community health worker navigator level, how you can do training for these folks and make sure that they keep their check as they progress. The option of people leaving their work and going out and going to a year of school and then coming back isn't really an option for most of these folks. And so we need to, if these folks are important, we're saying they are, we're going to need to step up. This may be the next place for us to sort of wake up and do the right thing, like we've started to do with integrated care. I hate there's so much, yeah. And one of the things I liked about hearing from Dr. Dobany about the competency-based training is that we're heading into a time when we might have a whole option of specialty titles to stick in this kind of general role. So you can have people who are certified navigators, certified health coaches, certified behavioral or community health workers, all these various certifications, when in fact, we need these folks to be generalists. And we need these folks to be generally trained in the 4 things we talked about earlier. And that, so we're talking about modular training, we're talking about modular competencies, and that the competencies are pretty clear in terms of what we need. And see, now I ran my mouth and look, we got an answers. So we started with Sarah, who says, for virtual BHCs, is there a recommendation on how to build relationship with the team to build expert status remotely? I present it to you folks.
So here at Cherokee Health Systems, there was about a year when pretty much all of our behavioral health staff worked remotely. There were only maybe a handful of us who never left to work remotely. We stayed here. And so we started using, this isn't a plug, but we started using Microsoft Teams as an in-the-moment HIPAA compliant communication strategy. We talk all day long on Teams, whether you're in the clinic or whether you're at home. So we built relationship that way, just staying in constant communication and collaborating, like, okay, if you get the Zoom set up here, I can go do that, blah, blah, blah. But like talking all day long. And then those weekly team meetings, Zoom, everybody's face is there. And so sometimes you got to be corny and do like a icebreaker at the beginning. Tell me one thing about yourself. One of my favorite icebreakers is to have people identify one thing they all have in common, but it can't be something as simple as we all work together. It has to be things like, we don't like wet socks, right? Like things like that. but you force them to find one really random thing they have in common. And then that builds, rapport. And so just do little things like that. We've done competitions, like if you do this and you get a tick mark, and then I did say condom, Whitney, and then you get a reward for getting the tick mark. But it is possible to build relationship even if you've never been in the same space. There's some people I've never met in real life, and I would talk to them the same way I would talk to them in person.
Yeah. I put in, now going up the chat, the address of a website that shows an enactment of a enhanced MA giving a patient on virtual care to the physician who works with the patient virtually, who brings in the behavioral health clinician. And in fact, and there's a role for a community health worker on the site. And it talks about how you do integrated care, team integrated care with complex folks, people with complex health burdens, I would prefer to say. And you see it in action. And it was created as a training tape for people who want to train people to do this work. Next, we get Rhonda, who says, can you also talk about how we might train clinicians on interacting with care enhancers? Dr. Dobity, did you have a experience doing that? I'm guessing you did.
Yeah, so we have a couple of ways we do it. And I think that one of the ways that we do it is actually the residents have something called social medicine rounds on one Thursday morning a month. And at that time, we invite the community health workers to come and participate in it. And during that time, they share their expertise and they're able to share ways of working with that patient and how they would do it differently, or how they would use their lived experience to enhance that care for the patient. The other thing that we do, and again, this is particularly in the setting of residency training. So it's a little bit different when you're talking about a non-residency based site, but we do have a community medicine block where residents go out and they're working with all of these different care enhancers in different ways. So I think the thing that we found the most helpful is actually having the clinician shadow, observe, get to see the care enhancer in their environment, in the work that they're doing. And that really elevates that work to help them to understand, oh, this is what this person can do for my patients or for our patients. So I think that that's been a great way for us to be able to work with clinicians.
Great. I decided to put in the workforce website that I talked about. Oh, thank you. You have your cat as well. I love it. I want to go back and underline something Dr. Winford said about an hour a week that's protected, that we wouldn't go away from, that we don't give away. It's really expensive for the organization because many, many organizations say that's too much. We can't do it. And I think, piggybacking on her presentation, that you can't afford not to do it if you really want to do team care. It's basic, it's minimal. Is that a fair statement, Dr. Winford?
Yes. Like literally, yes. There's so many missed opportunities to, just crowdsource, we all see things from our specific lens, but when you put it all together, you get a much more unified experience and understanding of the person. And I literally think we've saved lives because we've stopped and met for that 1 hour. And mind you, we have 23 clinics, and every single clinic gets between 30 minutes to an hour, depending on the size of the clinic and the patient volume, every single week. So like most expensive hour across the board, but it's worth it. We have saved lives.
All right. Thank you all very much. Thank you, Dr. Dobany. Thank you, Dr. Winford, so much for coming and presenting for us, for sharing your experience. Thank you, you folks out there who took your valuable time to come and be part of this work. And this is the last of our presentations, at least for the time being, but I'm going to share the screen again. And at the bottom of here, oh, doggone it, how do I manage to do that? Here you go, it's coming back. Down there, you see the address of the place where you can find all of the previous webinars. I think you will find them useful in your work. Thank you all again. And I'm just going to leave this here and let you folks, I'll leave it up and let you folks go on to the rest of your day. And in a couple of minutes, I'll take it down. Thank you so much again. Bye-bye. All right, I'm watching the participants drop off here. When we're down to nobody, we can break open the champagne that we have at our desks. Oh, we're not going to say anything that exciting anyway. So again, Ebony and Anna, this was wonderful. This was just great. I am delighted that you were willing to help us out. And Gina, thank you so much for herding the cats that we are.
Absolutely, Gina.
And
Thank
to-
you.
You had the hardest part.
Thank you.
And Anna, I'm so glad you were able to push
yes,
through.
able to. And
Thanks. Thank
Yeah.
you. And yeah, and it sounds like you're still experiencing some difficulty.
Yeah, it's the itchy scratchiness and like the random cough. But again, will I take an itchy scratchy throat random cough over hospitalization and intubation? Absolutely. I will
Yeah.
cough all day.
Yeah.
we have a
Yes.
itchy, scratchy throat in my family. My wife, Francesca, who has not had COVID, but by the bed, we have a little jar for her and a spoon. And in the jar is a 1-to-1 mixture of bourbon and honey.
I knew honey was going to be in there, but I missed that on
The
the
bourbon,
bourbon. I
Bourbon.
stepped the game up.
Kills the itch, the tickle.
Well, then I know where I'm going after work.
It kills everything else.
Well, yeah,
too.
and it's I learned that from my daughter's pediatrician. And I said, well, what am I going to do? She's coughing all the time. And this
Put some
wasn't
honey.
something where he said, give him, mix bourbon and honey, she'll be fine. And that's exactly what we did for all the years, bourbon and honey, and it works great. And in fact, it's calms people minimally. It's not a tablespoon isn't really enough to beat anything more. Thank you again. I'm going to stop it all now. But
I was going to say, my granddad, before he passed away, he abused alcohol, but he used to always say, if I got a cold, just take a shot of this whiskey and you will be just fine in the morning. But I never trusted him because obviously he was over consuming. I was like, no, granddad. And mind you, I'm like 16. Like, no, granddad, I'm not going to take a shot of whiskey and then end up being like you, is what I was thinking at the time. Right. Now I'm like, he knew what he was talking about.
He did.
Okay.
Knew what he was talking about.
See you all.
All right.
Bye,
Have a great rest of the day.
Feel better.
Thank you.